Evening, everyone. I'm Professor Thalang. Actually, you can call me Golf, Chair of ISN OCEA and Chapter Leader of ISPD Asia Pacific Chapter. It's a real pleasure to welcome you to the today ISPD Asia Pacific Chapter and ISN OCEA PD Case Discussion. Thank you for taking the time to join us from across Asia APEX region. This session are a fantastic opportunity to learn through real-world case-based dialogue by sharing our clinical experience. Today, case feature an 80-year-old man who presented with bloody PDF friend followed by UF failure. Dr. Thanawat, our first-year fellow, moderate from King Chulalongkorn Memorial Hospital, Bangkok, Thailand. So we encourage you to take part. Feel free to type questions in the chat or raise your hand to speak. When speaking, please unmute yourself and briefly share your name and where you're joining from. It's always nice to connect faces and places across our region. So we have a protocol that circulate to you via WhatsApp and also email. Dr. Thanawat, are you ready?
I'm ready.
Okay, let's start. Please.
Yeah, let's start about PD case discussion. Good afternoon, everyone. Today I will present a case discussion about PD complication with outflow failure and body PD effluent as the protocol that Dr. Taylor sent yesterday.
Go ahead.
Okay. Our patient is an 80 years old retiree from Bangkok. He presents with 1 day history of bloody peritoneal dialysis. History was reliable and obtained from the patient and his relative and medical record. The chief complaint is bloody PD effluent for 1 day prior to admission. Previous state that he have previously independent with ADL, ambulated with walker and capable of performing basic self-care tasks. 1 day prior to admission, the bloody PD effluent was observed during connection to automated PD machine. The patient denied fever, abdominal trauma, vomiting, hematemesis, melena, hematuria, or visible ecchymosis. He reported mild abdominal discomfort, but has no history of constipation, catheter manipulation, or trauma. The bowel movements were regular at 1 to 2 times per day, and daily urine output ranged from 800 to 1,000 milliliter. About the past history, he have end-stage kidney disease from cardiorenal syndrome. He start hemodialysis in 2016 and switched to PD mode since March 2021 due to intradiabetic hypotension. You have a high average transporter by modified PET. Sodium dipping is 5 mg per liter. His prescription is night intermittent PD 6 days per week, 5 cycles per night, and 10 hours per session. His residual urine output is about 500 milliliters per day, and the UF from APD is about 100 to 800 ml per day. He has no history of peritonitis before. And the other underlying is persistent atrial fibrillation with warfarin use and ischemic cardiomyopathy from single vessel disease with ejection fraction about 22%, and old ischemic stroke from cardioembolic cause, and hypertension, dyslipids, and gout. 6-month PTA on February 2023, he have admission with capsular pneumonia peritonitis with partial small bowel obstruction. The secondary peritonitis was ruled out, and this condition treated with ceftriaxone and metronidazole. The clinical improved and then switched to ceftazidime intraperitoneal for 21 days with complete remission. Both clinical and peritoneal cell count is normalized. About the personal and social history, he have a funfar allergy, no known food allergy, and deny alcohol, smoking, or illicit drug use. He denies family history of renal disease and malignancy. The current medication includes warfarin 14 milligram per week, and the medication for hypertension, dyslipid, and gout, as shown. The physical examination on the admission date. General appearance, elderly Thai male, alert and cooperative. The vital sign is no fever, and the blood pressure is 103/70 millimeters per hour. Millimeters mercury. The heart rate is about 88
Formal,
with
please, formal.
irregular pulse, and the oxygen size is normal. No pale, no jaundice, and respiratory system is normal. Cardiovascular show cardiomegaly by the point of maximal impulse is 6 intercostal space anterior axillary line with LV heaving, no murmur. The abdominal side soft and moderate detention, no tender, no rebound, no guarding. The PD catheter axis side show no sign of inflammation. And in the transfer set, that's the picture at the right side of the slide. The body effluent is noted from the transfer set. About the extremity is no edema and skin, no rash or ecchymosis or petechia.
So I stop for a while. You see the bloody effluent in the transfer set on the right hand side picture. Okay, go ahead.
Okay. What are the key problems and how do you approach the clinical of the patient?
And anyone want to volunteer to list the problem?
Okay, one of our specialists in training, Dr. Karil, is going to take a first shot.
Hello, hi, I'm Harry here. Hopefully everyone can listen. So again, this patient is actually an elderly male, came with bloody effluent. So first and foremost, I will take a bleeding history, whether this is a patient is actually an acute or a chronic bleeding. So number one, I think this patient has a first occurrence of bleeding, which I think it is an acute bleeding. And then other bleeding tendency that he might have, like a gum bleeding, joint bleeding, something like that, that could be leads to us thinking of acquired hemophilia in the elderly. And number two will be the history of warfarin use, whether I would like to see the previous INR target of this patient, whether it is a labile INR or is it within range of INR. And number three, I noted that there is a history of previous peritonitis before. And then, of course, I would like to know whether post treatment, whether this patient is actually apparently healthy, or is it there is some complication leads to it, like early satiety or abdominal fullness or even constipation that could lead thinking of EPS in.
Oh, wonderful, Dr. Karil, wonderful. So, do you have any immediate management plan?
You still asking Dr. Karil, or you want to ask someone
Yeah,
else?
Dr. Karil, because you're wonderful. He is fantastic.
Okay, Karil, back to you.
Okay, so in terms of immediate management of this patient, of course, I would like to investigate along the line after obtaining the history of it. So, of course, I would like to see the full blood count, see the WBC especially, and the differential count of it, whether this patient has any elevated of monocytes or basophils that could lead thinking of malignancy, hematological malignancy. Of course, the platelet count in this patient, if it is a thrombocytopenia in elderly, I would like to think of any causes of bone marrow that cause as a cause of it. And I also want to have a look at the coagulation profile, looking at specifically at the INR of this patient since he's on warfarin, and looking at the abdominal X-ray as well, whether there is actually a cocoon abdominal gas shadow, like a football sign that could lead us thinking of the EPS in this patient. And of course, CT scan of the abdomen or to lead the diagnosis of EPS is also will be helpful.
Oh, wonderful. Just curiosity. You're the first year or second year fellow.
Third year.
His third year lah.
Okay.
And doing his
Okay.
PD rotation now lah.
Dr. Thanawat, can you answer the problem list for the patient?
Okay.
So, okay.
Yeah,
So the
problem
patient have a
list of this
bloody,
patient is,
he always, Dr. Khalil already said that. So it's a bloody peritoneal effluents, likely hemoperitoneum, and so differential, including infection, trauma, and over anticoagulant. And the second one is because the INR quite prolonged, it's 10.6. Maybe it's critical for over anticoagulation due to warfarin. So maybe predisposing to spontaneous bleeding. And because the patient also have persistent atrial fibrillation, necessitating anticoagulant but complicating bleeding risk, and also ischemic cardiomyopathy and capsular pneumonia, peritonitis, and also the last one is hypoalbuminemia. So I so for the immediate management plan for this patient, Dr. Thanawat, and what is you doing for the patient?
okay. For the patient, we perform a push and pull test for assess the Tinkoff catheter malfunction evaluation.
No. Actually, we proved that
Initial.
for the diagnosis and initial management.
This is okay. For the body effluent initial management with vitamin K for 10 milligram intravenous and whole warfarin and whole PD because it has a body effluent and restrict oral fluid and monitor intake and output, urine output. After vitamin K administration, the INR was decreased from 10.6 to 2.1. And then we assess the catheter function by push and pull test. This test showed that the catheter have difficult to aspirate, and we return about when we push the heparinized normal saline 50 ml for fourth time, the effluent is about 10 ml of body effluent. And then we perform a rapid fill and then test. We use a heparinized PD fluid, 500 ml for full time, and the return volume of effluent is only 10 ml with bloody effluent and clot, like the picture and on the right-hand side in the slide.
So the patient proved to have bloody effluents, and you can see in the right-hand side picture. And because of the INR mark prolonged, so we initially prescribe vitamin K 10 milligram AV, and we can collect INR very quite fast. And also we hold anticoagulation, stabilize hemodynamics, and also assess bleeding sort, and also we try to preserve catheter patency, and we address comorbidity because after we collect the vitamin K, and then we try we see the blood clot in the inside the catheter, so we perform push and pull, and we cannot push and we cannot pull, so only we put the normal saline for 10 ml for 50 ml, but Actually, it's only 10 mil that's passed. So later we use the rapid fill and drain as Dr. Thanavat said. So the question is coming as do you use heparinized PD fluid or non-heparinized fluid for flooding and why? Anyone want to challenge for this question? Because I now prolong and you see the blood clot from the effluent and the catheter is clogging. So you're gonna use heparinized or non-heparinized saline or PD solution for push pull or flood the abdomen. Anyone want to challenge for this question? Dr. Dexter, do you want to share your idea?
Good morning, everyone. So I'm Dexter from the Philippines. So I think the warfarin and the heparin would target different cascade in the coagulation factor. So um, uh, theoretically, I'm thinking that there might be no problem with using heparinized um, saline solution or heparinized dialysate fluid as a flushing solution for this patient because his problem um, is targeted towards the coagulation factors that are affected by warfarin and not by heparin. So that's my thought.
Anyone want to share another thought? And maybe from Ethiopia. Dr. Tolosa, do you have any idea?
Hey everyone. So I'm Upshat Jyoti Tolosa from Ethiopia. So this is my actually first PD case discussion. So I'm trying to acquaint myself with the procedure and with everything. So I'm not sure if I'm the right person to answer this question, but I still think like using heparinized saline is the way since the peritoneum has not is not significantly affected with the heparin, right? So that's what I remember. Thank you.
Good. Well, actually, heparin, when we infuse to the PD catheter into the belly or abdomen, normally they will not absorb and will degrade it when they contact with the epithelial or mesothelial of the abdomen. But for this case, given the high INR and the risk of further bleeding, is balance decision. So heparinized dialysate can prevent catheter blocking, but should be used cautiously. So the decision often depend on balancing the risk of further bleeding versus the risk of catheter occlusion. So we don't have a good answer. But for this case, we use heparinized, but with a low dose. Dr. Thanawat, can you progress for the case?
Maybe Golf, if I could just make a comment before we proceed.
Okay,
I mean,
good.
yeah, you know, the dilemma whether you should give heparin to someone who's already having a bleeding manifestation in the PD fluid or not is one. I think that maybe the answer is not black and white. I think if you just have like a blood stain effluent, but there's no blood clotting interfering with the catheter function, maybe you could just flush it with, you know, your usual PD fluid. But this guy is already having catheter malfunction and blockade to the flow because of the clots, and therefore I think then you probably want to heparinize the PD fluid.
Yeah,
You know,
thank you. We do that. We use low dose heparinized PD fluid.
yeah. So it kind of depends on the clinical situation.
Yep. Anyone want to share any idea on that on this? Because it's no black. Then Surita said no black or white, but So we just like opinions on that because it's challenging test, challenging case.
Actually, Dr. Marjorie Fu is here as well. Maybe we can ask her because, you know, she's
Oh,
a
thank
lot of
you.
experience.
Where is Marjorie?
Dr. Marjorie, can we ask you about your
Yeah.
experience?
Yeah, I was just going to say, so when the first thing I said, we use 10 milligrams of vitamin K to reverse, it will take you ages to recoagulate the patient, right? So we don't usually use 10 milligrams, but you use maybe 1 or 2 and then gradually titrate, because otherwise it'd be a very long time before you can re-anticoagulate the patient. The other one, number 2, is you obviously don't know what the source of the bleeding is, right? Or maybe just seeping through the capillaries because INR is too high. Normally, heparin is a very big molecule, somewhere in the realm of like 60 kilodalton or something. So it cannot get through the peritoneal membrane. So we have surgeons who will get very upset when we put heparin into the peritoneum because the other surgery, they worry about bleeding, but it doesn't actually get into the system. So you put some of these abdomen, put heparin inside, I mean, check the iron APTT, it doesn't actually make any difference. So it's trying to localize within the peritoneal cavity. So why do we put heparin? Is because the heparin will prevent the clot happening, and also sometimes can also dissolve fibrin within the peritoneal cavity, right? So those are the 2 main reasons for doing heparin. I'm not sure whether how else are you going to, have you got the solution? How do you going to remove the clot? You already have, is it? Okay. I'll keep quiet.
Yep. Oh, thank you. You are wonderful idea. So, anyone want to challenge yourself for the next maybe procedure or next what should we do next for the case, because we try to flush, push and pull silings, and we fail with the flush PD fluid because of the clot. We cannot feel the fluid inside and also out, and cannot flow out. So anyone want to want to challenge yourself next? Any fellow want to respond for this? After we fail rapid fill and drain and push and pull silings, what else do you want to do for the patient? No one, any volunteer from Singapore or Indonesia?
Hello, hi. This is Durga. I'm a fellow from Malaysia, from HKL.
Hello. Yep.
Hello.
We hear you well. We hear you well.
Oh, yeah, this is Durga. I'm from HKL. So I was just wondering if the next step would be to probably, I would want to locate where the bleeding is coming from. So I would probably want an imaging before I manipulate the catheter any further. So probably would discuss with my radiology colleagues for a CT of the abdomen imaging, probably look at the vasculature as well, and then probably try and locate where the bleeding is coming from.
Okay.
With regards to the catheter, I think there are options like brushing or urokinase, but before I introduce any further manipulation, I would probably want to locate the bleeding.
Wonderful again. So, Dr. Thanawat, can you progress for the case after we fail fill and drain, push and pull? What do you do?
After we find the patient have the problem of blood clot in Hancock catheter and transverses, and they have a problem of outflow failure, we progress to instill with thrombolytic agent. We use Actylite or RTPA 4 ml and add normal saline up to 5.4 ml and fill in transverses and then cross catheter develop for 2 hours in catheter. The result is we aspirate around 10 ml of body effluent with clot, and then we repeat the the procedure for 3 times, and we test
But
with rapid fill and then
the
test
reason
with
that
fill, the very
we
nice.
the Thanavat, do you hear me? So the reason that we fill the another 3 times because it's not success. It felt that we cannot drain for it out. So we have no choice. So we try again with RTBA lock the catheter. And then after 3 times, what do you do? And also, do you do image for the case? What your signal? It may be not good.
Okay. After that, we consult a surgeon for
So
brush.
for we fail with RTPA lock for total 4 times, and then we do CT imaging, right, and also pain KUB for checking the abdominal problem.
And this is a chest X-ray and film KUB of the patient. The Tinkoff catheter is located in pelvic cavity in good position, and the bowel ileus was observed in the film KUB. So we have give the medication of laxative for relieve the constipation, but the outflow failure is persist.
So in this time, so we do imaging and we asking for CT peritoneography as many fellow asking for, but the catheter still not working. So what else do you do for the case? Anyone want to challenge yourself? We fail push pull. We fail dissect flushing, and also we fail RTPA thrombolytic agent locks. Anyone want to challenge Dr. Dexter? And any comments on this or any? Dr. Dexter, are you there?
Yes, Professor, I'm thinking of another way.
Thinking, okay. Anyone that
I'm not sure if we can do a peritoneoscopy.
peritoneoscopy? You peritoneoscope, right?
Yes.
And for the patient condition, and because it's almost a day, the patient stop dialysis. So do you plan anything for the patient while waiting for peritoneoscope and manipulate the catheter?
Oh, so as mentioned, probably we'll continue with monitoring the input and the output of the patient. If there will be prolonged time before the catheter can be fully addressed, then probably a temporary shift to HB for the patient.
So unfortunately, because the patient transferred from HD to PD because IDH, intradiabetic hypertension, so it's not possible that we transfer back to HD. So while waiting, so Dr. Thanawat, do you have the flow guideline, what we should do for the case?
Okay.
when the patient got the UF failure and we stop dialysis.
Okay. Outflow failure in PD may result from various causes. There are two main causes. That the first is intraluminal obstruction like thrombus or fibrine. The second cause is extraluminal obstruction like constipation, full bladder, or mental wrap or adhesion. And how to differentiate or to separate and find what is the cause of outflow failure. We conclude in the table of clinical presentation and cause of outflow failure. The first, if dialysis inflow is slow or sluggish or incomplete, the cause may be from catheter kinking or intraluminal obstruction. If the dialysis inflow is slow or incomplete with associated with abdominal pain during installation of fluid, the cause may be from tip entrapment or trip at the subdiaphragm. And in the patient, they have outflow problem. The dialysis outflow, if is intermittent or position related, it may be from catheter malposition or migration, or from external obstruction like constipation or menstrual wrap. If the dialysis outflow is intermittent with presence of clot or fibrine in the effluent, the cause may be from intraluminal obstruction, like in this patient. And the flow for outflow failure management, the first is to rule out peritoneal leak and find the clinical clue for the cause of outflow failure, like from kinking, entrapment, or obstruction. And this patient may be from obstruction because we have a problem of outflow failure, and we find the clot and bloody effluent from the transfer set. So we have to exclude external obstruction like constipation or mental wrap, and we think that this patient have an internal obstruction with a fibrine clot or clot in the transfer set. So the way to manage the clot in the catheter obstruction is the first is rapid saline and heparinase flushing or push and pull test, and then we'll if the problem is persist, we perform the thrombolytic agent lock in the catheter. If the two ways for correct the fibrine clot is fail, we shift to perform intraluminal brushing by endoscope to transfer sets and brushing the clot. If all of the three way it fail, we have to consult surgeon for revise or replace catheter for the next step. Okay, and this patient,
Stop for discussion a while. So anyone, when you see this flow and the patient have inflow and outflow obstruction, blocking, and fail for heparinase dialysis and also thrombolytic agent. Anyone, and we cannot transfer the patient to HD because the patient have history of IDH. Anyone have any idea what should we do next? Maybe this quite tough for fellow. So probably I gonna ask Dr. Machuli because you have most experience in PD here. And followed by Lily.
I don't know. Okay. So did you you ask interventional radiologists to put a guide wire in and see if there's any that they can take away the clot? Interventional radiology can help.
Okay, yeah. And how about Lily? What's next that you want to do? What is the case?
Yeah, just to share that we have been avoiding using heparin saline or even RTPA for flushing the PD catheter because we have a very bad experience of quite bad bleeding. And you know that whenever there's bleeding, it stimulates adhesion, and later on it can develop EPS. So we do not want bleeding from there. But going back to this patient, where we have tried heparin flushing and even a thrombolytic agent, I think the next step we can do intraluminal brushing. I have no experience of intraluminal brushing, but we have a nephrologist in one of our hospital where he does this. So it needs to be someone who is skillful to perform this procedure, where you can remove the clots from the holes and fenestration of the PD catheter. Yeah, that's my input. If the next step is because I think it was mentioned that the patient has no choice, that it's very difficult to convert the patient even to temporary hemodialysis while waiting to sort out this problem. So I think the next step we should try intraluminal brushing by someone who has expertise on this.
Okay, great, wonderful for both of your opinions. So the patient we try intraluminal blushing, but the blushing cannot pass through. Not this one. Not this one. Not, go back. So for the patient, we consult intervention radiologist, and he tried to pass the blush through the catheter, but it's not it's failed because it's quite tight, and he tried to attempts, so it's not working.
Oh no.
So we have no choice. So we consult the surgeon. We consult surgeon. To use endoscopic manipulate the catheter, or probably remove and reinsert simultaneously. But during the because the surgeon to do endoscopy in my center, we require to have a general anesthesia.
Yeah.
And when we do general anesthesia for the case, the patient got profound shock.
Oh.
So we have to stop without any manipulate the catheter.
I think the best golf is to remove every set in the same setting, like you mentioned, maybe laparoscopic or even peritoneoscopic or percutaneous.
Because to endoscopic, we need to the surgeon need to have a GA.
Yes.
So not possible. But maybe if nephrologist can remove and insert, so probably it's gonna be help. Because they are quite afraid of bleeding, because the INR prolonged, even we collect with vitamin K, but we also lock with the thrombolytic agent for 4 attempts. So we're gonna review the case. Dr. Thanawat, what finally we do for the case?
Due to the patient condition is unstable and high risk for general anesthesia, we consult gastroenterologist for use ERCP guidewire and swing tip cannula to infuse the anti and fibrinolytic agent intraluminal at the clot. And we perform at fluoroscopy guide insertion of ERCP and swing tip cannula, and the cannula is insert to the Tenkov catheter to the finding the localization with the contrast field, and then the guide wire is puncture followed by direct thrombolytic infusion in the clot. This is in the right hand is the video of the procedure that the ERCP guide wire with swing tip cannula with infusion of thrombolytic agent. And after instill the thrombolytic agent in the clot, there is a successful salvage of PD catheter confirmed by fluoroscopy with contrast media that's passed through the catheter into the abdominal cavity with via its distal end.
So let me rephrase this. So actually, we insert to guide. The first guide wire is a ERCP guide wire because it's quite long, and this guide wire can pass through from the proximal end to the distal end to penetrate and puncture the clot. And we also insert the second one is a cannula. It's called it's cannula, right?
Yes. Yes.
Swing tip cannula. So this one we want to targeted infuse the thrombolytic agent. Why we do this? First, we need to penetrate the clot, and second, if we infuse the thrombolytic agent directly from the proximal end, so it's gonna be leaked along the side hole of the PD catheter. So that's why we need to use something that hit through the clot. Like for this case, we use swing tip cannula, and when we hit through the clot, and we see by fluoroscopy, and then we infuse the thrombolytic agent, and thrombolytic agent will lysate the clot directly, and also pass along the tip along the guide wire to the end to the tip of the catheter. So this is quite complicated procedure. We use both catheter to try to lysate the clot, and we call this technique is a targeted thrombolytic agent. And after we prove by you can see go back to the last slide, Thanawat. No. Go back. Not
go back.
Forward. Go back.
Sorry, may I know who performed this procedure? Is it the interventional nephrologist or the radiologist?
Radiologists, they have no experience on this. So we asked gastroenterologists and also my fellow and me sit aside. So you can see here is a marker. Marker is a cannula. It's a swing tip cannula, and you can see the ERCP guide wire penetrate to the end to the tip of the catheter. You can see here. You see the tips is penetrate the clot. And when we see you can see the swinging tip slowly penetrate the catheter. And when we see the target, so we infuse the thrombolytic agent. Okay, and then Thanawat go ahead to prove how success of the technique.
Okay. After we have performed targeted thrombolytic agent in clot, we test with rapid fill and then test with PD fluid, 1000 ml for 4 times or about 4 liters. The effluent initially drain 2.2 liters with slightly bloody effluent. And when we repeat fill PD fluid for 4 liters again, the effluent volume is about 4.2 liters and clear effluent and good inflow and outflow, no clot seen. And the video and in the right hand side is the flow from the after we drain the PD fluid from after procedure. Is a good flow.
You can see the outflow is very fast. Okay, what next? And we also perform the CT peritoneography to show the success of the case and also finding the cause of bleeding. And because Dr. Caril mentioned about EPS, because the case have a previous peritonitis from Klebsiella pneumoniae, so we take a pen CT abdomen and also perform peritoneography as well. Thanawat, you read the CT feed abdomen for the audience of participant.
Okay. This CT peritoneography. There's plain study show small hypodense intraperitoneal fluid in right subhepatic and perihepatic area. When we fill the PD fluid 2 liters with non-ionic contrast, and we have performed a CT at 1 hour and 4 hours after contrast media. They show normal distribution of contrast material and dialysis in intraperitoneum, and no sign of intraperitoneal leakage or hernia or loculate fluid collection or abscess in intra-abdominal. And the catheter tip is loop in the left lower abdominal region without kinking or contrast field around the tip catheter. So this result, summary of the result is the catheter is in the left lower abdominal region, but no leakage, no hernia, no collection is, and no sign of peritonitis from this CT peritoneography.
You should say the PD on the right position in the cul-de-sacs, and also the peritoneography equally distributed in the belly of the patients, and also we found no sign of no cause of the bleeding, no EPS. Peritoneal membrane is not thick, and we see no cocoon and calcification of the peritoneum. So the case is probably hemoperitoneum is caused by prolonged INR, and also and when we give the vitamin K by internist and causing the PD clogging by blood clot, and we fail push pull flush with PD fluid and also thrombolytic agent and brushing as well. And finally, we successfully salvage the catheter by using targeted thrombolytic agent. So anything that you want to take home message for the audience? Thanawat, anything else that you want to show? Okay, maybe you have a last slide, right?
Yes. About case progression, after we perform a direct thrombolytic infusion by ERCP and swing tip cannula, he is able to resume automate PD and was discharged from the hospital in stable condition. However, during follow-up at PD clinic, the patient represent with APD alarm due to outflow obstruction Despite multiple attempts to troubleshoot, the catheter PD was no longer feasible. So hysterectomy benign hemolysis due to IDH and his multiple comorbidity and hysterectomy decided about the renal replacement therapy mode, transition to palliative care. And about take-home message of this patient, body effluent in PD caused by anticoagulant, menstrual-related catheter trauma, peritonitis, and EPS, malignancy, bowel ischemia, or other. We have to follow the flow for access the body effluent to find the alarm feature like shock, fever, or sign of peritonitis, severe abdominal pain, like is may have to perform the CT whole abdomen for evaluate the secondary cause of bleeding. And then we awareness of anticoagulant because of when we have INR prolonged and they have bleeding in the abdomen, and we use vitamin K to correct the coagulopathy, and then develop clot in the transfer set and have a problem of outflow failure. If you use vitamin K for correct the coagulopathy, we need to flush the catheter for check the function of catheter regularly. And then how to troubleshoot the catheter malfunction. In the patient, they have a good inflow, but outflow is very slow and low drain volume. Suspect catheter obstruction from the clot. So the initial management is rapid flush by a push and pull test. And then we use heparin saline because of they have a clot.
You should
in the
not repeat the
catheter.
whole thing, just brief take-home message.
Okay. And use thrombolytic agent like RTPA to lock the catheter or intradermal brushing.
Okay, maybe I can help you for briefing. For reflect on the novel techniques, so the ERCP, guide and string tip cannula is a method for targeted thrombolysis. It's an excellent example of intervention innovation. And post-procedure imaging is confirmed both technical success and restore catheter function. So this approach highlights the value of cross multidisciplinary creativity in managing complicated cases, especially in this case. So anyone want to have the final comments or any idea or want to share your opinions on this? Or any question from you? You can text or you can raise your hand. Anyone? If no one, we're gonna close before time. Another Sunita and team.
Okay, Golf, congratulations first of all to you and also Dr. Tanawat. A very nice case discussion in which we learned quite a lot from the basic management and causes of their bleeding fluid to actually becoming more innovative. I guess the one other thing is message is that stay close to your other colleagues from other disciplines, because this is how we can actually develop innovative approaches to patient care. Thank you very much.
Thank you. But unfortunately, the case only clot only fail. So actually, we palliative and the patient passed away now. Okay. Thank you, Sunita, also, and thank you all for your valuable time and thoughtful participant. And special thanks to Dr. Tanawat for deliver such a thought-provoking case, and to everyone who contributed to the discussion. Please share the learning opportunity with your colleague, and we looking forward to welcoming you again at our next ISPD Asia Pacific chapter and ISN OCEA PD case discussion. Before we end, I'd like to invite Dr. Lily, our new Deputy Chair of ISN OCEA from Hospital Tunku Jaffa, to share a few words and highlight the upcoming ISPD Asia Pacific chapter 2025 meeting. Dr. Lily, are you ready?
Yes, thank you very much, Professor Kanjana Bush, or Golf. Thank you, Dr. Tanawat, and for a very interesting presentation. I would just to highlight to welcome everyone here to our 11th Asia Pacific Congress and Malaysia Society of Congress in Malaysia, which we held at the Kuala Lumpur Convention Center at the Kuala Lumpur Twin Tower from the 3rd to the 7th of September. So please submit abstract, especially for the young trainees and nephrologists, where the deadline is the mid of June, and also the early bird. I hope for all the developing country, please take the opportunity to be an ISPD member to obtain the benefit of a discounted rate. And you can have an institutional membership of 10 people to become a ISPD member with a USD of 175 USD. So I will welcome you to come to Kuala Lumpur. See you all. Thank you.
Thank you very much for joining us, and see you next time. I will let you know probably next month or next couple months. We'll see who's gonna be volunteer. Thank you so much, and have a great day and great evening.